Outside of contraceptives, we have fertility and reproductive meds. We also have things that we're going to help our menopausal women get through menopause with to kind of help with those symptoms. What happened? Your ELOs listed here. All right, talking about menopause. So again, this stuff is not going to be testable, but this is just giving you the background so that you can understand the mechanism of the drugs whenever we're talking about it. So I'll let you know once we hit our drugs and what's going to be testable. So when we're looking at this, our main hormone is estrogen. That's what, again, is signaling that uterine lining can grow, helps with formation of breasts, different types of growth processes that we talk about with like metabolism. And then remembering our progesterone is essentially preparing our body for and maintaining that pregnancy if there is a pregnancy that occurs, okay? So understanding, again, we're still looking at our estrogen and our progesterone. Looking at menopause, understanding that the definition of menopause is when someone has not had a cycle or a menstrual period for at least 12 months or a year. Usually this happens in someone's early 50s, but depending on when they started their cycle, it could happen prior to that. Understanding essentially the estrogen and the progesterone levels drop, and so that's what stops them from having that cycle. You will have some of your patients coming in who are in their early 40s, mid 40s, and they'll start to complain of having different types of vasomotor symptoms and things like that, and they call it perimenopause, but that doesn't mean that they're in that menopausal stage just yet, okay? So you're essentially going to be helping with treating some of the symptoms and the complaints that your patients will have as they go through menopause. The average of how long this lasts can vary depending on the patient, okay? So some people are kind of uncomfortable for quite some time. So when you're looking at your estrogen deficiency here, just understand that it causes what's called vasomotor symptoms. So atrophy, osteoporosis, things like that are what we're worried about, cardiovascular disease. When you're looking at your progestin deficiency, just thinking about the breakthrough that they can have with essentially spotting, because again, it's trying to maintain a healthy atmosphere, right? And if I don't have that, or I have an imbalance in these levels and it's starting to decrease, then that's where you're starting to see some of these symptoms. Heavy periods, very painful periods, like you'll see lots and lots of bleeding in some of these patients. So just understand that you getting their CBC, making sure that they're not becoming anemic during this time frame is something that you also have to watch out and kind of control for that patient, because they may not know. They may just come in and say, like, hey, I'm just starting to feel very, very tired. I'm bleeding a lot. That's when you're starting to look out for these things. When you're looking at your vasomotor symptoms, so again, big thing is like the hot flashes, the night sweats, like overwhelming, just feeling hot and heated. That's going to be probably one of the #1 complaints that you're going to have your patients coming in to talk to you about, and that's usually what you're treating. Some patients will experience this more at night because a lot of people, they get a little bit hotter at night, but this can happen all throughout the day. You'll see sometimes where people will like whip out a fan out of nowhere and they're like fanning themselves because they're having a hot flash. This is a part of those vasomotor symptoms. Your genital urinary atrophy that can occur, again, because of that decrease in the estrogen, a lot of women will start to feel vaginal dryness, pain with sex, different things like that, because of the loss of the lubrication that they're having. So again, one of the things that you can help and counsel them on with treatment is what we're going to be looking at. So when you're looking at this, just understand that a lot of the before menopause, okay, so pre-menopause, we have all of these things that are typically regulated in our women. And then with all of those hormonal changes, those hormones are controlling everything. They control that vaginal environment a lot. So whenever those changes start to occur, there is a lot of discomfort. You will see sometimes some of your patients come in with more UTIs and like painful urination because of those the imbalance now that they're having with these hormones, okay? The pH has changed and therefore everything kind of becomes a little off. All right, Big thing that you're going to be worried about is getting that patient history, making sure that you're understanding, because of some of the drugs that we are going to use, and the increased risk of some things like cardiovascular risk, cancer, osteoporosis. You need to make sure that you're getting that history so that we can avoid certain things if we can in those patients who already have an underlying health condition with one of those things. So again, just making sure that you're getting a good past medical history, and then individualizing that therapy based off of the information that you obtain from the patient, okay? It's not going to be the same for everyone. Some people, you can kind of be like, oh, you have menopause, and you know kind of which lanes you're going to go down. The older that they are, the more likely you are to hear about that osteoporosis risk. But other than that, you're kind of dealing with like blood pressure, because that's a big one that we talk about, and if someone has had cancer or any type of cardiovascular disease. Those are your top three that you'll typically see by the time someone is hitting menopause. Looking at your menopausal hormone therapy, or MHT, you have your estrogen and progesterone, or you will have estrogen alone, and then you have your SERMs. Remember, we talked about our SERMs a little bit when we talked about what condition? That starts with an O, osteoporosis. So that's where we had talked about those SERMs before. So we'll look at this and kind of decide how you're going to tailor your treatment based off of your patient's history. All right, so this is where we're definitely looking at our medications, what we have available to our patients. If somebody is just complaining of those genitourinary symptoms, the dryness, the pain that they're experiencing whenever they're having sex, you can offer some of these meds. Some of your patients are not going to want to take hormones because they're already experiencing these fluctuations, and you may have someone who is just greatly opposed to them, or they have some contraindications to those hormones. So this is all of our non-hormonal options that we have. So again, if they're having just those genitourinary symptoms where they're experiencing the dryness, the pain, they don't want those hormones, you have a vaginal lubricant that's available. Buying those over the counter, we do not have those for the patients in the pharmacy, but just making sure that they understand again that this is not anything that's helping against STDs. This is specifically just to help with their comfort while they're having sexual intercourse. Your SSRIs that you have, these are good options if they can't, again, tolerate that hormonal therapy. For instance, they have a history of cancer, they have like a cardiovascular risk, and we don't want to use that hormonal treatment in those patients. This is where these come into play. Paroxetine is one of our big ones that we love to use first line for those vasomotor symptoms. And remember, our vasomotor symptoms are the hot flashes and the night sweats. That's like your big symptoms that you would see. And then looking at your SNRIs, not as popular as us using our SSRI, but you have your venlafaxine and your desvenlafaxine. And the doses of these are going to be lower than what someone is taking for depression, but if they are taking the medication for depression, then it should be helping decrease those effects for the vasomotor symptoms as well. So if you had someone who had both conditions, you would not decrease the dose to treat vasomotor symptoms and neglect the depression, right? Like you're going to treat for depression, and if you see that they're not helping, the dose for the depression is not helping with those vasomotor symptoms, then that means that you may have to add on a different medication to help with the vasomotor symptoms because your SSRI isn't working to cover it, okay? And then off-label, gabapentin pops back up again. Gabapentin, we use gabapentin for everything. But you see that all of them are going to help with those vasomotor symptoms, but what you see that changes is looking at the other conditions that they may assist with. So your gabapentin, because of the side effects of drowsiness that is sometimes caused by it, you see that it helps with sleep. Your oxybutynin, we use this to help with bladder control, so if someone is having discontinence, this is a good option to also help them with that frequency that they're experiencing. And then the clonidine and methyldopa, the side effect profile is just not fantastic. So we don't use them a lot. Your clonidine was one of your anticholinergics that we had. Your methyldopa was the alpha-2 agonist, but we just don't use them often, okay? So if you're looking at these, just understand that they're not something that you're gonna go to first line. We're looking at our SSRIs and then our SNRIs if we needed to. Here are some of the things that some of your women are probably gonna come in and they're gonna say, hey, I tried this medication and it's probably not going to be working for them. Or they will tell you that they want to continue to take these while they're taking their prescribed medications, and you should just tell them they're not FDA approved, you don't really recommend it. But what we have, you have your red clover, your soy isoflavones, black cohosh, and then other herbals and oils that some patients may use to kind of get them through this time. So again, for you to recommend them, you're not going to recommend them. We're going to stick to our meds that we talked about previously, and then some of our other hormonal replacement that we're going to talk about next. So just understand that they may work, but if they worked, your patients probably wouldn't be coming into you to complain about their symptoms that they're experiencing. So once you put your meds on, tell them to take these off. Okay? If they're trying them and they're telling you that they work fine, then great, let them keep doing it, and then eventually they may come in there to you to tell you that their symptoms have returned. Okay? All right, your MHT or menopausal hormone therapy. When we're looking at this is going to be a big game of, am I using estrogen alone or am I adding it with progestin, and how do I want them to take that progestin if I do add it on? When we're looking at the benefits of us having that estrogen on, we talked about a lot of the side effects that we experience when we're dealing with high doses of our estrogen. But when we're looking at what they can do, they can help stabilize the mood for those patients, but it's not for us to treat mood disorder. Okay, so if somebody is coming in and that's what their issue is, these are not what we're not putting them on hormone therapy for that. But what we have seen is that in our patients who have who are going through menopause, that it can kind of stabilize the mood swings that they're experiencing. Helps with the sleep, and then also your general urinary symptoms that some of your patients will be feeling, as well as the vasomotor symptoms, will all be helped with these meds. Again, your big hurdle is the patient's past medical history of what is going to exclude them from this therapy, and their willingness to take hormones to treat them during this time with those symptoms. Okay, so that past medical history is your big hurdle. So when we start going through these meds, just looking at the contraindications is going to be the big thing for you to say, like, okay, if I have a patient who has this, they can't have this. If I have a patient who doesn't want this, they can take these. Okay, that's how you're going to look at this lecture. And then your osteoporosis risk is going to be decreased whenever you're using your estrogen replacement therapy as well. All right, adverse effects. These are the same things that we looked at whenever we were looking at our contraceptive therapy, and we were talking about how we're trying to keep our estrogen dose as low as we possibly can, around that 20 micrograms, because we're worried about a lot of these cardiovascular and thromboembolic risks that can occur whenever we are continuing to give our patients estrogen, especially at higher doses. So then we're again looking at cancers, endometrial, as well as the breast cancer risk increasing. So that's why, again, if somebody is has this background in their history, we're more cautious with the doses that we're giving them, or if we're going to give it at all. When we're looking at the endometrial cancer, if somebody has an intact uterus, we then give them the progestin with that estrogen. They're not going to take it alone. Okay, so whenever you say an intact uterus, that means that they have not had a hysterectomy. If a patient has had a hysterectomy, then you're not worried about their uterus anymore. Okay, so understanding those two terms is very big when you're knowing when to add on progestin versus when you don't have to add on progestin. Intact uterus means they have not had a hysterectomy, their uterus is there. Okay. The reason why we're doing that is that so that they don't have that unopposed estrogen, which is still going to be released in their body. If you have a hysterectomy, then there's no estrogen that you're worried about. So that's why we don't worry about the progestin in that situation. If we have unopposed estrogen, we have an increased risk of all these adverse effects that we're talking about. The cancer, the CV, the thromboembolic events, okay? So that's why we're adding on that progestin in this situation. And then our clinical use, again, preventing them from having those symptoms that they'll experience while they're going through menopause, and also looking at the fact that if somebody is at risk, at an increased risk of having osteoporosis from them going through menopause, this will help with that, because remember we said that this was going to decrease their chance of having osteoporosis on our previous slide. So again, we want to use this like we love using this in our patients who do not have a uterus, because then we're not worried about that unopposed estrogen. If they have the uterus, what medication are we adding? Progestin, okay? All right, so looking at progestin, we're going to talk about all these different formulations that they have. The most popular one that we use is going to be your medroxyprogesterone, which helps decrease that irregular bleeding that those patients are experiencing. Because remember, when we looked in the very beginning slides, we said that our progestin dealt with all of that irregular bleeding that they were going to have. So it's going to decrease that irregular bleeding, help decrease the risk of cancer. Remember, we just saw that on the previous slide with our endometrial cancer. And decrease the risk of them having that osteoporosis. We kind of use it prophylactically whenever we're talking about our estrogen. Whenever they are using both the estrogen and the progestin, there is still a risk that they can have some bleeding still occur. So just kind of be on the lookout for that. Let your patients know that it is still a possibility that they can have that occur. If they don't have that uterus, again, the hysterectomy, do I have to give them progestin if they don't have a uterus? No. Okay. Keep asking y'all, because I want you to remember when you're giving it versus when you're not giving it, okay? Adverse effects, all of the things that we see here, right? Bloating, irritability, like those mood swings, all the things that we have essentially already talked about when we were looking at some of the stuff with our contraceptives, our combined contraceptives. So understanding that when you are given progestin versus when you are not given a progestin. And if I have a hysterectomy, then I don't need to have a progestin on board. If I have an intact uterus, never had a hysterectomy, I need to have my progestin. Okay? This is just looking at, again, our long-term risk. If you were keeping someone on these medications for a long period of time, you see on the left, it has all of the good effects that we've talked about, and then on the right, it has all of those bad effects that we talked about, which was the increased risk of cancer, the CV risk, the clot risk. All of those things are listed here to kind of give you just a picture of what was going on. This was just this very huge study that they did with a lot of women. I think it was like over 150,000 women who participated in this study, and this is kind of what some of the information that they gathered, and that's why we know now, okay, let me give progestin if they have that uterus and so on and so forth. So this study was like a big, huge marker for us to kind of back off on how much we were using that hormonal therapy as well. So it's a great study. All right, looking at our MHT, understanding that these are not something that is going to help your patient not become pregnant, okay? So if they're seeking a contraceptive, they still need to have a contraceptive, even though we're talking about the same exact meds that we were looking at with contraception, the same hormones essentially. These are not formulated in the same way. So what you're looking at when you're doing MHT is you want a low dose, for a short period of time, usually 2 to 3 years, but definitely less than 5 years, because you will have some people, again, who are going through menopause for years. They will experience these symptoms for a very, very, very long time. So we don't want to increase those risks that they're having from those adverse effects of us using it from a long period of time, So that's why we try to keep our therapy as short as we possibly can. You're going to continue to check in with your patient to make sure that they're not having any of those side effects. And you'll check in at that like 3 month to a year mark and attempt to stop them on this treatment. If you stop them and their symptoms occur again, then you add on another 3 months and then you try to pull back again. And you keep doing that because you won't know when they're actually complete with that menopause, like those symptoms that they're experiencing. You're not going to know until you stop the meds, because your meds are essentially masking the symptoms that they're experiencing, which is what we want. But then you have to make sure that you're not just putting them on them and leaving them there, right? Because then my risks are going up. So that's why you'll check every 3 months and then you put them on. And you're like, okay, you've been on this for, you're going to pick your sweet spot. If somebody says that, like, I've been dealing with these symptoms for 2 or 3 years now and now I want treatment, that means they could be towards the tail end. So you can check on them sooner than that person who's like, oh, I just started this a month ago. They're probably gonna go through it for a minute. So bring them back, you probably can bring them back in a year, safe to say, and then you take them off, see what happens. Give them 3 months. If their symptoms come back on, you're gonna put them back on for 3 months, and then you'll keep doing that until you can get them off. Looking at your regimens again, look at what we see here again, okay? So just make sure that you're understanding, when am I giving my progestin versus when I'm not giving my progestin. And then when you're looking at your conjugated estrogen, there's different types of estrogen that we'll look at. And I'll show you the list of all of the medications that you have. But essentially, when you're doing this, you're taking this, again, in your women who have the hysterectomy. So there's no uterus that is there, okay? And then when you talk about those genitourinary symptoms, please don't sleep on or forget the lubricant, okay? Not necessarily just jumping straight to MHT. And sometimes we'll put our patients on MHT and we will still tell them to have the lubricant because that pH has now changed that whole vaginal environment. And sometimes a lot of them will not want to have sexual intercourse because of the pain that they're feeling. And the lubricant helps a lot, just like the meds do. You're just tackling it in 2 different ways, okay? So don't forget about the genitourinary symptoms. The other thing is that we have several different formulations of our estrogens and progestins. So when you look at them, we have tablets that they can take, and we also have gels that they can use vaginally, different formulations vaginally that they can use. So we'll look at all of the different ones that we can go through. Okay, these are the different types of ways that you can give the therapy to the women who are going to be using the progestin in addition to their estrogen. So you have the ones who gets progesterone? Your progestin? Intact uterus, right? So when you're looking at your cyclic is essentially mimicking a normal cycle that woman would have, okay? So you're giving this, and I don't need you to remember all of these calendar days. Just understand that there's the 3 different types. Your cyclic, and then you have your continuous, where you're giving both of these things together. And then you have your intermittent, where you're doing them on separate days. So you'll do your progestin treatment, and then you'll say, okay, stop the progestin treatment, and then you'll do your estrogen treatment. And then you just keep doing it off and on. The reason why we don't love that one is because, again, the lack of consistency. When your patients don't have consistency, they forget where they are. And it's very, very easy for them to be like, oh, was I on day 2 or 3 of my progestin? Like, I don't know. So if you did do this, write out days. Monday, Wednesday, Friday, Monday through Wednesday, you're doing this. Friday through Saturday, you're doing and do it that way so that they know exactly where they're going with this. But again, intermittent is not one that is used often. In cyclic, I see continuous is the one that I typically dispense for because they're just taking something every single day, and it's easy for the patient to remember. Okay, here are your different oral options that you have. So make sure that you're seeing when the difference is. So here are your oral options that you have for your estrogens. Don't worry about the strengths, just understand that there's lots of different strengths, but look at the names that you have of your oral estrogen products that are available. All of them are there in bold. And then here are your vaginal estrogen products that you have. So if I'm telling you that my symptoms aren't so much vasomotor, but they're more genitourinary that I'm worried about, so like if I had that atrophy or if I had a lot of that pain, then these are some of the options that I would prefer to use because I'm not exposing them now in their entire system. I'm going to the source. I'm putting that medication where they're having the symptom, which is in the vagina. Okay, so you have creams, rings, and then they also will insert some of these tablets vaginally as well. Okay, so all of your different options are listed here. Again, don't worry about the dose. A big one that we see used is the conjugated estrogens, the vaginal cream. But some of the biggest complaints that I hear about that is they have to usually, I tell my patients to wear panty liners, because sometimes whenever they get up the next day, the cream starts to come out because of gravity, like they're standing up now, and then they will discharge it. So I usually tell them to wear like a panty liner or something, so that way they can just take it off and throw it away, so that it's not just sitting on the outside, because some people will have skin irritation from the medication just sitting on their vagina. So looking at your clinical indications, again, listed down here, told you already, like if they're just complaining of some of those, the genital urinary effects, the only one that you're worried about an increased risk of systemic effects with is going to be your fumarate, which is your estradiol acetate. Okay? So that's why you also see that this one is very good for those vasomotor symptoms, because they're getting that systemic exposure even though they're just using a ring. So they have the direct genital urinary, but they're also getting that systemic exposure as well. So if I came in and I told you everything is just breaking down and going through menopause, I have the hot flashes, I'm having the genital urinary symptoms, oh, I have something for you, have this fumarate, okay? And then our transdermal patches. So when you're looking at this, again, look at the names and then look at your counseling points all the way to the right. When we're talking about these, if somebody has very sensitive skin, then please, again, be aware that they're putting something on their skin topically and they can easily have a rash. Also, if you have somebody who's working out a lot, these patches, if they use the patch, can fall off very easily as well. If they still want to stick with a patch, I tell them to just put like some of the tape over it while they're working out, so that they, like not over it, around the borders of it. Medical type tape to put over there so that it can adhere better. But again, like we talked about with our birth control, with our patch, we told them to rotate. Same thing, we're still going to tell them to rotate. Then you have your transdermal gel. The package will tell them how they're going to pump it and prime it. But again, making sure that if somebody is in contact with kids, if somebody is in contact with a male who does not want to have all that estrogen on them, that they're putting it in a spot that they are covering and that they are washing their hands afterwards. Okay? That is a very, very big thing that people forget to do. And then looking at your transdermal spray, again, just making sure that they're putting it where it's supposed to belong and that they have the nozzles turned the right way so that they're not, again, letting anybody else get exposed. So your big thing here is making sure that you are, if you're having a transdermal route, that you are only exposing yourself as the patient and not anyone else who is coming in contact with the patient, okay? So putting it in a spot that is covered. We'll talk about this when anyone uses testosterone, same exact thing. Make sure that they're putting it in a spot that is covered. And then you see the nausea, vomiting, headache that some people will tell you that they're experiencing with estrogen is going to be a lot less because of that route. We've changed the route, so you're therefore going to have less side effects whenever we're looking at this. These are just all of the examples of the ways that you can get these medications. So just very, very, we are very diverse when it comes to our estrogens and how we can get them to our patients. Here are all of your progestions that you have. When we're looking at this, again, just know that we love our medroxyprogesterone. Okay, we use this a lot. So I want you to look at your formulation that you have available here. And then again, our clinical use. We talked about Mirena when we did our contraceptives. But just look over here at your clinical use that you have, because if your patient is coming with certain symptoms, then we want to be able to treat them. When you're looking at your Megestrol, when we talk about this, our Megace, a lot of the times we treat our patients who have cancer. You'll see this used a lot, or your patients who have like bulimia, anorexia, for that weight loss, because this will help stimulate their appetite. We sometimes see this prescribed in that instance for those patients. So look at some of these, because we do see different variations where some are better than others. So still sticking with that Megestrol, like if I'm a cancer patient, a lot of your cancer patients will start to lose weight because they do lose their appetite. And so this is a good one, again, to help those patients, not only with their symptoms that they're feeling, with the cancer and from their chemo, but this is helping them also kind of maintain that weight and the appetite that they're used to. So pay attention to all of our different meds. I'm not really worried about the is it a PO versus IM or IU? I'm not worried about that. I just want you to be familiar with your options that you have that are progestin. Looking at your micronized progestin, make sure that you're watching out for your patients who have a peanut allergy, because these capsules are like suspended in on the inside of the capsule, it's like a peanut oil on the inside of it. So if they're allergic to nuts, they cannot have those micronized progestin. And then here are our combo products. So instead of us telling our patient to take 2 different medications, we can be like, hey, here's this one that you have that's in combo. So looking at these, just make sure that you're, again, aware of the names, not worried about you knowing the strengths or the dose. And then when you look at your Prempro and your Duavi, understand that your osteoporosis prevention for those patients are going to be treated when we're looking at these meds. And then your vasomotor symptoms that are going to be caused because they are systemic by the menopause that they're going through, this will also be treated with these meds, okay? So when it's saying respectfully, so it's saying your Prempro and Duavi. So Prempro is specifically looking at your menopause, and your Duavi is looking at your postmenopause. So that we make sure that everybody is clear on what that means, how I wrote it that way, right? All right, our SERMs, they're back. So you have your raloxifene, your osfemifene, tamoxifen, and then your conjugated estrogen or your Duavi that we talked about. So mechanism, same thing that we saw before, looking at that estrogen, decreasing the bone resorption, which is why we saw it in our osteoporosis, because it was helping us not have that the osteoclast activity that we were having. And then when we're looking at our tissue and how it is sometimes absorbed in different tissues, you see that it's an estrogen antagonist when we're talking about breast cancer. So it is a very diverse medication because when we're talking about the different side effects, like those CV risks that we talk about when we're looking at estrogens and the risk of endometrial cancer, you can see that it's an agonist in that aspect, okay? So antagonistic when we're looking at the breast tissue, but agonist when we're looking at the cardiovascular and your endometrial tissue, okay? Your antagonistic effects that you'll get also are going to be some of those vasomotor symptoms, so the hot flashes and the night sweats that we talked about. Looking at your use of your raloxifene or your Evista, very popular choice for you to pick. Prevents the breast cancer and osteoporosis, specifically looking at your postmenopausal women. Can also treat the osteoporosis, which is why we saw this when we were looking at osteoporosis, we would use this for treatment in those patients. So again, just those are the main ideas. Looking again at your contraindications, we talked about these already when we did our osteoporosis lecture, so another review for you to look at. But if they have a history, big one that you're worried about, if they have a history of that VTE, we definitely want to make sure that we're avoiding it. And then again, postmenopausal women is where we're looking at this. Our interactions, bile acid resins, they interact with most of our meds that we have. Your warfarin, you see that your PT is decreased. And then your thyroid hormones, again, make sure that you separate them. We talked about these. These are the same interactions that you saw previously. They're just up here again. Looking at your osfina. So when we're looking at this is more so looking at your urinogenital use. Can increase the risk of that endometrial cancer that we keep talking about whenever we're looking at our estrogen. So not something that we're going to use in anyone who is pregnant or anyone who has a history of a DVT, okay? So not for breast cancer, used more so for like the dryness that your patients are going to be feeling. And your osfina or your osmifene is not for osteoporosis, so not FDA approved for osteoporosis. Remember, some of your SERMs are. This one is the one that is not used for that. which is why we didn't see it in our osteoporosis section. Adverse effects, again, those vasomotors are back. CV risk, endometrial cancer, the same things that we keep seeing over and over and over again. Contraindications, if somebody has had cancer due to their estrogen exposure, the DVT risk, if they've had endometrial cancer. The reason why you see this undiagnosed bleeding, and that's with anything, even when we were talking about our contraceptives, I told you always need to figure out what the underlying cause is first. So it needs to be a diagnosed reason. You need to know that there's not something else going on, that there's not some type of cancer or any other problem that's happening as to why this person is having that vaginal bleeding. Drug interactions, just making sure that you're not giving it with other estrogen products, and then lots of CYP interactions. So that's all you need to remember is CYP interactions. I don't need you to remember exactly which ones. And then you can have displacement of other medications that are bound. So just understand that that may increase the activity of some of your other medications. Tamoxifen, this one is treatment and prevention of breast cancer, not FDA approved again for our osteoporosis, which is why you also didn't see this one. Adverse effects, contraindications, very similar. The contraindication that is not the same here is going to be your visual impairment that some of your patients will say that they experience. So just watch out for that. Make sure that when you're bringing them back in, that you are having them tell you about any visual disturbances that they're experiencing. Same drug interactions that you're seeing, and then understanding that if somebody is also on an antidepressant, that the effects of our tamoxifen may be decreased by that antidepressant. All right, our conjugated estrogens with your bezodoxifene or your Duavi. This one is again for your osteoporosis treatment, but not, osteoporosis prevention, but not your treatment like what we were talking about with our raloxifene, okay? Your mechanism is activating those estrogen receptors. You can look and see what the role is of each of the ones as far as like what's acting as your agonist. So your bezodoxifene is the one that's acting as the agonist of those estrogen receptors that we have. Clinical use again, vasomotor symptoms, we're looking at specifically our menopause, but when we're talking about the prevention, making sure that you're understanding that again, these are your postmenopausal women. Adverse effects, same things that we were looking at. Please watch out for that throat pain and that if they're having difficulty swallowing, any of those issues, because that could be an indication that there's some type of cancer that could be potentially forming in those patients. And then looking at your limitations. Make sure, like we talked about with all of our hormonal replacement therapy, that you're using it for the shortest duration of time. Definitely a year is what we aim for, but some of your patients are going to end up on that 3-year time frame, and very, very rarely should you hit that 5-year, but after 5 years, you need to start making sure that those patients are getting off of that hormonal replacement therapy, okay? And then looking at your prescribing for your postmenopausal osteoporosis, just make sure that they are on that high end or a high risk patient, because if they're not, again, you're exposing them to these increased risks of cancers and things like that, and it's something that may not even happen to them, okay? So that's why you see the us making sure that we are very, 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 very cautious when we're prescribing these medications. Some of our other treatments that we have, our clomiphene or our Clomid. So you will see that this medication helps with our ovulation. Essentially what happens is it will help that woman produce more eggs, essentially. When you're using this, ovulatory failure in your women who are desiring pregnancy, and then they have started to use this in males who are experiencing infertility, but most of the time we see this in our female patients whenever this is prescribed. You usually are only going to do 3 courses, so usually that means about 3 months. And what happens is, I do want you to look at this dose, because what you're doing is you're starting on the 5th day of their ovulation cycle, so the woman has to track when they're ovulating, and then they start on that 5th day. Okay, so that is very important. It's not something that you're just prescribing and they're gonna take every single day. This is specifically to help them with that ovulation, to increase them having a chance of that egg being released to be fertilized to actually conceive. Adverse effects, again, just some visual disturbances. They'll sometimes have vasomotor symptoms that occur to them. And then the ovarian enlargement at the larger, higher doses is because, remember, we're stimulating them. Just look at that mechanism, and then that adverse effect makes sense. And then the increased possibility of having multiples. So that is the one thing that you're going to need to definitely make sure that the patient is aware of. Most of the time, they're not going to be coming to you for this. They'll usually go to OB for this, but you could see one of your patients who is going to an infertility specialist who is on one of these meds. The issue with them is that more than one egg could possibly be released, and then if more than one egg gets fertilized, they will have more than one baby. So that is the big thing here, okay? It's the last side effect, it should be the first one, okay? Because then you have to deal with more than one kid at a time. Looking at your aromatase inhibitors, so these are more so for your estrogen-dependent breast cancer patients. Off-label, we do see that we can help with ovulation for these, with these. These are like, I see these typically tried after you're looking at using your Clomid. So usually we use the Clomid first, unless there is a reason why, because we usually get sometimes a better result with using Clomid. But these are also options that are available for your patients. Mechanism of action, inhibiting the production of that estrogen by blocking the aromatase, i.e. aromatase inhibitor, okay? When we're looking at this, our drugs that we have, letrozole, anastrozole, and your exemestane, all of these are oral medications that the patient can take. Again, they are off-label though when we're looking at our ovulation induction, but more so for our patients who have that breast cancer that is estrogen dependent. Your progesterone antagonists that you have, again, exactly what they're saying is their mechanism, antagonizing that progestin activity that they have. When you're looking at your mifepristone and they're both mifepristone, different brand names, just like when we talk about some of our other medications, like our Wellbutrin, and how they'll give it a different brand name based off of the indication that you're using it for. So our mifepreps, you won't really see used much right now anymore. Termination of pregnancy up to 7 days, and then your mifepristone or your Corlin is usually used for your patients who have Cushing's, okay? So those are your progesterone antagonists.
And is that a typo? Is it 7 or 70 days?
70.
It is 70? Wow, okay.
Because remember when people typically like it's causing them to have an abortion, right? And so depending on where you go and you're aborting a baby, different people have different cutoffs, and the procedure in which you're trying to abort the baby will change depending on how far along they are. So when we use some of our oral meds, essentially they're trying to cause contractions to make the baby come out, even though, bless you, the baby isn't ready. And so that's how you're having the termination of the pregnancy. But when some are further along, they actually go in and like remove the baby. And so you can't do that most of the time effectively with the oral option. So that's why they have, yes, yeah. All right. Your androgens. So when we're looking at these, when you think about androgens, think about like a sex hormone, essentially, produced by testes, ovaries, men, women, we both have them. And we're trying to stimulate the sperm being made when we're looking at our androgens. It also helps stabilize certain things in our women with our estradiol and us being able to produce that. We do have where some people are going to abuse some of our androgens. So a lot of them that we dispense are going to be controlled medications because of the potential of abuse. They have horrible oral bioavailability, so these are IM injections for us to be able to get past that first pass. We're gonna have them inject themselves. So if you do order the testosterone, which we're gonna talk about, we will tell you to do a syringe. You see the exceptions with your orals that are available. These are not typical ones that we prescribe. Most of the time you're going to do IM, but you have your methyl testosterone, which is oral, and then you have your buccal testosterone, which has that increased risk of hepatotoxicity. But again, those two we don't use for the most part. We will give them the vial themselves. You will prescribe an entire vial, and we dispense it out of the pharmacy. They have a needle and they inject themselves. Pay attention to the vial size that you do order, because some providers will try to order the very 10 ml vial, and then the patient has a lot of extra testosterone just kind of hanging out. So make sure you're paying attention to the vial size whenever you're ordering those vials for them. So looking at our clinical use, we have osteoporosis and anemia. Just remember what I have underlined, okay? Postmenopausal osteoporosis and you're senile. That's all I need you to remember from there. When you're looking at your males, again, most of the time we're using this in our males who have low T or low testosterone. They may be experiencing issues with having sex, so like impotence, bless you. You can see where some people have hypogonadism, so several different reasons why we use it, but essentially it all stems back to them having low levels of testosterone. And your females, looking at this, you have your hypopituitarism that we will be using in conjunction with our estrogen, so they're not just getting this androgen alone. And then for some of your patients who have different types of cancer, especially if it's metastatic breast cancer, you will see this used quite a bit in your females. Unapproved use, that's the abuse that we're talking about, which is why we have a lot of patients, or that's why we have it as a control medication now, is because of the fact that people using it to kind of like bulk up and improve their athletic performance and their appearance. So a Schedule III drug now because of that high abuse potential, and that doesn't matter which formulation you're talking about, the buccal, the oral, the IM, all of them are controlled. Adverse effects, when we're looking at this, you can see a lot of issues with their cholesterol kind of being disturbed, and so you'll have patients who are going to end up having high blood pressure, having high cholesterol. A lot of patients will also have mood disturbances as well. Looking at our adult males, you see that this causes a decrease in the viable sperm that they have. So they kind of are shooting themselves in the foot, like whenever some people are using this, especially with the dose, a higher dose, you're more likely to see a lot of this occur. And then again, when you're looking at the priapism or the impotence, all of those things can occur, gynecomastia. So just again, dose related, you will see some of these kind of increase with a higher dose, but it doesn't necessarily mean that's always the case. Looking at your males who haven't hit puberty yet, you're going to see that their growth is going to be stunted. So that's why I always used to try to follow little Hercules to see what happened to him. But he looks like maybe he wasn't using steroids after all, because he looks like a normal sized person. But if a kid is using steroids, you will see that like they're going to be a little bit shorter. And then for your females, just think about them becoming more masculine. They'll start to grow hair. Their voice may change. Some of their genitalia may change and like get larger. So just be aware that's how you can kind of see where your females have extra testosterone. Here are our different options that we have for our testosterone that are available. You see that again, most of them are IM, and then you have your transdermal, you have oral options. Again, the biggest one that we are going to use are going to be one of these IM formulations. All of these are controlled. Just know that there's a lot of them, okay? There's lots. And then looking at your comments. The other thing that I want you to be aware of is that you want to make sure that you are not exposing anybody who does not want testosterone. So the guy who wants to sleep with his shirt off, who's using testosterone, rubbing against his wife, and now she has facial hair, remind him it's his fault because he exposed her to the testosterone. So we always tell people, put it in an area and cover it up. would be if you do have your transdermal. You don't see this with your IM. We're good with our IM, but the issue becomes whenever we have any type of topical formulation, people forget that. They put it on, and then they're just sharing the love, okay? So look at your comments also to understand where we're going. Making sure also that when you're prescribing that transdermal, it has different strengths. But when you're looking at your strength, what I mean by the different strength is that you're gonna know what your deficit is and how much testosterone you're trying to provide to your patient. Some of your patients can get away with one patch, and some of them are gonna need more than one patch, okay? And then you have the same issue where some of your patients will tell you that their patch is falling off. So the same remedy that I tell you all the time, make sure that you tell them to get some of that tape and kind of put it back on. Don't cover the entire patch, just the outside so that it actually adheres. So all I want you to know from here, lots of formulations, and look at your comments, okay? And we'll start here when we come back from our break. Okay, essentially, we're suppressing the pituitary, releasing that FSH and that LH that we've talked about how many times, which ultimately is going to affect the testosterone that that person is going to be producing. So we look at this, our clinical uses are endometriosis. So those patients not use much due to what we, I forgot where I was going with this, about how much we use this. Endometriosis, you see that we have our GnRH, and that's why. We don't use this as much because we have our GnRH that we will particularly use, and then they have a better side effect profile, our analogs, than some of our danazol. Also, you see that with this one, we have a PO option versus us having to do those injections. And then again, yes, we have that oral option with our testosterone, but it's not something that we are going to typically see used. We'll typically see our IM injections used for those. So more of our things, again, remember we're stopping our FH and our FSH. So you're looking at all of these different uses. We've talked about a lot of these different uses when we're looking at our anti-androgens or our androgen antagonists. We said that when we are using these meds, especially if we're using androgens or testosterone in our women, that we would see a lot of these things. So thinking about reversing a lot of these things in our women because it's an antagonist, right, or an anti-androgen. We're getting rid of those things that we would see caused by us using androgens. So if you remember your side effects from our androgens, essentially these are used to treat everything that we could see occur from us using an androgen. BPH is one of the ones that's kind of off there. So essentially thinking about this, what they're doing is blocking that alpha-1 constriction and allowing the bladder to relax and that person to be able to use the bathroom the right way. So a lot of these patients, they have a lot of constriction, they'll have incomplete voiding. Some people will strain because they feel like there's more urine in there, but there's not really anything in there for them to get rid of because of how tight. And some people can strain so bad that they are starting to enlarge the size of their prostate if they're a male, and then that creates lots of other problems, okay? So just understand that with this, we're trying to help decrease a lot of the symptoms that people will experience from that incomplete voiding, the frequency. A lot of your patients will be waking up in the middle of the night. That's where we get most of our use from this class of medication. Talked to you already about the mechanism, but when we're looking at our different drugs that we have, you have your terazosin and your doxazosin that you can use for BPH as well as hypertension. So we've kind of seen these pop up a little bit. Your alphazosin is specifically for BPH only, and then your tamsulosin, which is more selective, that alpha-1 alpha for BPH only as well. So looking at that is very important when you're talking about your alpha blockers. And then you have your 5-alpha reductase inhibitor. We have one that we're going to talk about, which is your finasteride. And sometimes you will see where we use both of these together. You'll see an alpha blocker with a 5-alpha reductase inhibitor. So it's not uncommon where both of these are put on board together. Looking at our mechanism for our finasteride, again, 5-alpha reductase inhibitor. And then looking at this with what our DHT or our dihydrotestosterone is doing, that's the one that is increasing the prostate and growing, which again, you'll see where you're getting your different PSA levels and things like that to make sure that somebody doesn't have cancer. A lot of your patients who have prostate cancer will have an enlarged prostate. So with this, you're just trying to decrease the muscle working and getting larger, so you're decreasing the BPH progression and the growth and trying to decrease the size, and hopefully that will decrease the symptoms that those patients are feeling with the frequency, the incomplete ability to void. That is our goal when we're looking at our finasteride. Again, you see here 2 brand names. When you see your Propecia, think more about, it's not approved for women, but we do off-label use it for hirsutism in our females, because again, it's blocking that reductase in the androgen, which means that they have less testosterone. So that's why we will see this used for the most part. As far as being approved for women, it's not FDA approved, but you will see it sometimes used in our women off-label for that indication. Again, looking at your Propecia, male pattern baldness is why you will see that one and that one. If they have the brand name of Propecia, you will see that this is not going to be something that is approved for most of our women. But if you're talking about it as far as Proscar and that brand name, then where most insurances are going to be okay, because now you're saying it's for BPH instead of something that they would consider cosmetic, like your alopecia. Okay, so that's the difference. Same exact thing, same drug. Okay, they just branded it in 2 different ways for different indications. You'll start to become more angry as you learn about more drugs. Again, looking at our use, symptomatic BPH can be used with the alpha blocker, like I already told you, and then unapproved or that off-label use, again, and where we would see it used for our women. Adverse effects, decreased libido, ED, so just think about sexual dysfunction, right? Because I'm decreasing the amount of testosterone that is in their body, so therefore they are going to sometimes have issues, sexual performance issues. And then not safe during pregnancy, so much so that even in the pharmacy, if someone is pregnant, this is one of those pills that we don't allow them to count. And we also have a separate tray for it. It's like one of our hazardous drugs, okay? So if somebody is taking this and they have a pregnant spouse, they should not be in contact with them, their sperm, so they would have to use contraceptives while the person is also taking this medication as well, okay? So nothing to do with a pregnant woman, nowhere close, they can't touch it, and that includes the semen, okay? Sexual dysfunction. So when we look at this is going to be something that patients are going to come in, they're going to want to talk to you about it, they are going to need medications because this is a big part of some people's lives. Uncomfortable conversations, sometimes a little awkward, but they are conversations for you to have with your patients and make sure that they're practicing safe sex. If they don't want to become pregnant, the contraceptives, like what we talked about before. So thinking about ED, just understand that it is caused by an increase in blood flow via your nitric oxide, making that CGMP, and that's what gives the erection. If you're taking things like medications for blood pressure, what do we think is going to happen to someone who is trying to have an erection, especially if they have a high dose? It's going to be difficult for them. Okay, so that's where we see a lot of these side effects coming in now. You're understanding like, oh, this is where that comes into play, right? So big thing from here is just understanding, hey, this person is going to present to you. You're going to diagnose them with erectile dysfunction. Several different reasons as to why that can happen. So we have our antidepressants on there, our medications for blood pressure, which is not on there, your diuretics, your opioids, antihistamines are a big one as well. So just remembering where your issues are coming from if you have a person who does get diagnosed with ED. When we're talking about these meds and as we go through these meds, make sure that you understand when we're using these, they are very limited quantities that you are going to be able to prescribe per TRICARE formulation and what they will cover. So when we get through that, I'll kind of talk to you a little bit about that. Smoking, alcohol, all the things that we continue to tell our patients to avoid These all can kind of deal with why some people are having ED. So if it is the alcohol, just again, try not to prescribe a medication. Our goal would be to decrease their alcohol intake, okay? That's your big thing there. And that's one of the big ones that you're gonna see. A lot of people will go out or they drink because that's a thing that some service members do. And then they will start to have problems with performing sexually, and then they'll wanna come in for a medication. Counseling them on the alcohol intake is gonna be a bigger thing. So your PDE5 inhibitors, we've seen these. The big one and the most popular one is going to be your sildenafil or your Viagra. Then you have vardenafil, avanafil, and then your tadalafil is the one that lasts for 36 hours versus the 4 with the other one. So when I think about tadalafil as a 36 hours, like ta-da, for 36 hours, long time, okay? Versus your other ones are 4 hours. I'm trying to help you remember things, okay? They might come up. Your clinical use, you will see, oh, that was a good one and I didn't even do it on purpose. Y'all didn't catch that? Y'all are, let me just look at the clock. I can't look at y'all's faces when I talk about this stuff. You will also see this used for PAH or your pulmonary arterial hypertension. The dosing is different and you will see that they will use this on a daily basis versus how we're using it in erectile dysfunction. So some of these have that brand generic name like what we talked about where we'll approve it differently, and it's easier to go through insurance for PAH versus the quantity that you're allowed to dispense when you're talking about the indication of erectile dysfunction. And then you also have it in there for BPH. Your adverse effects, again, a lot of people aren't really worried about your adverse effects, but hypotension is something that some of your patients can experience, and then the priapism where they have to end up going in and having you like draw out the blood with a needle from the penis because the erection isn't going down. So that is something that can happen, and we do have that in the ED more often than not. And then the vision changes, understand that that is also a big thing that some of your patients will complain about as well. So when you're looking at these meds, understand that the mechanism of them inhibiting that PDE, so therefore you have your CGMP around for a longer period of time to cause the erection, which is what is desired. Bless you. All of these medications do need some type of stimulation to occur. So they're not like, oh, I'm just taking this med and then like nothing happens. They have to have either the sexual contact or the idea of, sexual contact for these medications to actually work, okay? Here are all of our different medications. What I want you to look at is the drug that you have that is available, and then the comments. When you're looking at this is what I was talking to you about with some of your medications and us again with this branding. So when you look at your Viagra, which is also Rebatio, you see that you can use it for the PAH. A lot of these meds, they found out, they cause an erection when they were using them for these other indications. And then that's why they started to use them for erectile dysfunction. It was like a side effect. And they were like, we can make some money off of this. Let's call it Viagra. When in actuality, it's the same thing as that Rebatio that they're using for PAH. Different doses, but same idea. So that's what I was pointing out to you earlier. So looking at these, again, you see our use ED, PAH for the most part. And then the comments, just make sure that you're understanding that you're being careful with all of these medications when you're talking about renal issues, so less than that 30, except for your vardenafil, and then understanding when you're taking them prior to the sexual encounter. So whether it's an hour or 30 minutes before that encounter, understand that that's whenever they're looking at trying to take it to make sure that it works. So my big thing that I want you to understand is when you have hepatic issues and when you have renal issues, which meds you're avoiding versus which ones you're taking, and then understand the drug that you have available. And then just overall, in general, for your counseling point to your patient, they're taken up to an hour prior to that sexual encounter. Here are some other medications that we have that you can see the interactions with our PDE5 inhibitors. So when we talk about these, this is where you're asking that patient who comes in with a heart attack, hey, are you taking Viagra? And if they can talk to you, what we experience is a lot of people don't tell us. They're on their way out and will not tell us what's going on, okay? So understand that you have to try to have somebody looking that up already, like doing your med rec to see if you can look that up yourself so that you don't ask that question, but it's definitely always a question that you're gonna ask. So when you're looking at your nitrates, like so something like your isosorbide, your alpha blockers and alcohol, all of these things are synergistic and they can all cause that hypotension to occur. So that is why we're very worried about it, because we can bottom out that patient if we give them one of those nitrates with one of our PDE5 inhibitors, which we just said could cause hypotension as our side effect. So that's why we're worried about all of these things listed here. So your nitrates, your alpha blockers, and your alcohol. When we look at our tamsulosin, remember that was our only selective with our alpha-1. So it was an alpha-1A. So with that, we have a benefit of having less hypotension because it is more selective for its target. So therefore, we're not experiencing as much symptomatic side effects with our hypertension. So tamsulosin is all by itself. It's more selective, less hypotension. And then looking at your inhibitors and inducers, just again, remembering, oh, it got cut off. Just remembering again what we're looking at when we have something that is an inhibitor versus what we have with something that's an inducer. Those are the big things though. I want you to remember your nitrates, your alpha blockers, and your alcohol are our big things that we're trying to make sure that we're not bottoming out our patient because we have an increased risk of the hypotension that could occur in our patients. Okay, here are some other options that are a little more invasive. We do have patients who use them, and again, counseling is going to be very critical in our patients. So our alprostadil or our Caverject, this one is a PGE1. And what it does is it causes vasodilation of that smooth muscle, so therefore they have the erection that they're trying to achieve. As you can see, this is an injection. They are injecting themselves in their penis to help. Now, the reason why you're using this, and the typical patients that we use this in are going to be our patients who have like nerve damage. Right? So them just taking the Viagra or taking that pill, it's still, if there's an issue with how my nerves are going to transmit, that's why you're injecting directly into the penis for these patients. So look here at your ED as to why we're using it in these patients, okay? So that it kind of makes sense for you. Even your patients who have like psych issues, right? It doesn't matter if you give me this pill, I still I'm not able to connect these two systems together. So I'm still gonna have an issue. So that's why this is like more invasive, because these people are not having just issues with ED, they're having like actual real underlying causes as to why that blood flow is not there. And then looking at your starting dose, you're gonna witness that first administration. So you order the med, they'll come and pick it up from the pharmacy. You will see them administer that first dose to make sure that they're not having a lot of the side effects that we are going to be worried about, like extreme hypotension, things like that. Also, we have Muse or alprostadil, which this one is like a little pellet. So think about how you would look at, bless you, a suppository kind of. And so they have this little tool, which you can see pictured here. They put it on the end of their the urethra, and they essentially push the pellet in. So you're worried about your patients who have issues where they could potentially not be able to get rid of that erection, or something that's going to have caused them to have an underlying issue as to why they have a priapism. So anyone who has like curvature, sickle cell, very like difficult underlying conditions are where we're worried about these. Any people who have like any type of fibrosis there, Peyronie's, all of these things are going to be where whenever they're trying to push down, if they cannot safely push without disturbing that scar tissue, they may make their issue even worse, okay? So again, examination, conversation to get that history to make sure that they are not going to have any type of anatomical deformity as to why they're not able to use this medication properly. This does only last for about 30 to 60 minutes, so they need to make sure that they get to it if they're trying to use this. They didn't have a medical term for that. Some additional things that you'll see used with your ED is going to be, again, our FDA approved versus our non-FDA approved. You will have patients, again, come in for those non-FDA approved. If they do that, again, they're coming into you because they're probably not working. They should not take them in addition to their prescribed medication. So Euhimbine is the non-FDA approved. Looking at your FDA approved, you have your androgens that are listed there and your alloprostadil that we just talked about, which is in those two where they can inject or they have the pellet that they're putting in. Your Muse is the one that you're putting in, your Cabaject and your Edex is the injection formulation of it. Female sexual dysfunction. So when we talk about our androgens, remember we said that they are FDA approved, but we have one medication that is FDA approved, and that's going to be your filbacin or your Addy. This is the only option that your females have that is FDA approved for their sexual dysfunction. Now, we do have several other things that we need to get to prior to worrying about sexual dysfunction in females and in males. But you want to make sure that you're looking at all of your non-pharm options prior to prescribing this medication. I have yet to dispense this medication, probably because there's lots of other things that are going on underlying wise, hormones, psych issues, several different things. So this is where you kind of have to get in the weeds with your patient and kind of personal and like, hey, you know, are there marital issues? Or are you stressed about something that is making, you know, sex be like the last thing that's on your mind? So you have to talk to them through those things first before you're just throwing on a medication, because there could be some other type of etiology that's going on. If they're going through menopause at that point, right? Like that also may decrease my ability to want to perform because I'm having vaginal dryness and I don't have treatment for that yet. So again, probing and asking those questions are very important before you get to prescribing our flubanserin, okay? You see PDE5 inhibitors, which is why we don't use them. They're not proven to work. And then our dopamine is very good for some of our patients, but again, we're worried about the side effects that some of our dopamine can have. So this is kind of, if they have the comorbidity of the Parkinson's, you're getting a 2-in-1. And that was another thing that I wanted to bring up. The off-label uses, when we were talking about treating our menopause, make sure you go over them, because if you, just in case like I write a question that has a comorbidity, those had the comorbidities listed with them as to why you could do like treat two things with one med kind of situation. So the example that we were talking about was gabapentin, and potentially if I told you that somebody wasn't able to sleep because their symptoms were so bad, what have you, then you could say, all right, I can use gabapentin because this will help with both of those things. And then your herbal supplements, again, more invasive, making sure that your patient is being sterile whenever they use this, but you would not, I would not tell you to recommend anything herbal to your patients. But you see, people were rubbing the oil on the clitoris, but what was found was that a lot of people were getting infections or they have burning because it's getting into their urethra. Or if my hands aren't clean and I decide to do that, another issue, right? So you're gonna stick to making sure there's no underlying issue that's causing this dysfunction, the sexual dysfunction, and then you have your one medication that we have, which was our Addy. So our mechanism, understanding that we don't know how it works all the way yet, but we think that it does have some serotonin and dopamine type of activity, which were two things that we said we did see that kind of work. So if you think about that, like the underlying stress, depression, all those things that we were talking about could be what helps in this situation. This is also used in our premenopausal women, looking at us not having any other reason as to why this is their issue. So it can't be like, I don't like my husband, which is why I'm having sexual dysfunction right now. Can you prescribe me this medication? Your underlying issue is still there. right? Like, I don't like my partner, I have sexual dysfunction. No, you don't like your partner, you need to fix that, that's the dysfunction part of it. Don't just give a medication, okay, is my point. Looking at all of these other problems, again, just figure out what's going on first before you run to this medication, is essentially what this is saying. Premenopausal, premenopausal, premenopausal. Our postmenopausal women, they're going through menopause, which is typically why we see this issue. And it's not something that's going to be like making this woman want to have sex all the time. Now, this is trying to just help with an imbalance that we could potentially see there to increase the desire for them to want to have sex. So if somebody is not having a lack of, if they do not have sexual dysfunction, you should not be prescribing this, okay? Adverse effects, hypotension, again, like we saw with our PDE5 inhibitors, and then just some drowsiness and dizziness, not a horrible med. Contraindication, somebody who's using anything else that also could cause hypotension, so alcohol, any of our other meds that we talked about with our PDE5 inhibitors, and then don't worry about the dosing, but understand that, again, not something that we want to keep them on for a long period of time, especially with that potential of the dopaminergic activity that it has, and us not knowing the clear mechanism of it. It is newer, which is also why we don't want to leave them on it for a long period of time, because we don't know what's going to happen long term. Okay, I am going to see, nope, it didn't come back on. So this next lecture that this wonderful building doesn't want to let me connect to my internet for. So I don't know why this is not loading for y'all, but I will be able to, I think I'm gonna have to, I will post it. We started at what time? 12:30?
11:30.
11:30? Okay. Okay, let me try again, because what I want to do is I want to try to cut us